I'm Graham Jackson, I'm a GP. I'm Chair of NHS Clinical Commissioners and a Senior Clinical Advisor to the NHS Confed, chairing this today. This webinar is part of the NHS Reset campaign, which is about looking at the way forward beyond coronavirus. It's led by the NHS Confederation, and today we're focusing on diabetes. I won't loiter on the introduction because we've lost some time. I'm going to get into our presentations quite rapidly. Four excellent speakers today: Arthur Carr, Stephen Wiggcroft, Naresh Kanimeli and Wasim Hanif. And as they come on, I'll ask each presenter to introduce themselves more fully at the start of their particular session. The format, we'll run through four brief presentations, and Arthur's going to start with a national diabetes overview. We'll follow through about patient flows, then a digital issue, and then about leadership. And we'll have some time for Q&A. The Q&A, unfortunately, will be slightly compressed because of the loss of time. We will aim to finish at 6 o'clock on time. So, Arthur, if I could ask you to come on screen, come and join in, and I'll let you pick up and you give your presentation on the overview position. Thank you, Arthur.
Thank you very much, Graham, for that introduction. And again, for issues of time, and so that we have some time for Q&A as well. Quick overview. First of all, my name is Arthur. I'm a consultant in diabetes based in Portsmouth, and a national role in looking at as one of the national specialty advisors for diabetes. So very briefly, overview: COVID-19, as has been documented well enough, has had a huge impact on individuals with diabetes. Some good papers of reference in case you wanted to look at, which has recently come out in the Lancet Diabetes, but is also on the NHS England Diabetes website. And to summarize that particular papers, if you have diabetes, you do have higher risk or worse outcomes. Obviously, the most important factor in there is the age, which would be a non-modifiable factor, but other factors in there have been primarily your glucose control, again confirmed by studies done by Ben Goldacre and his group called the Open Safely Study. Your weight has a bearing, your ethnicity has a bearing, as does your deprivation. Background conditions such as heart failure and renal problems also contributing. But the single biggest determinant across the COVID-19 picture has, of course, been age. So as regards any beneficial changes, every cloud brings its own silver lining. So some of the acceleration of digital has been quite impressive to look at. For example, in a chronic condition such as diabetes, I personally always believed that a lot of work could be done in a very digital way. I don't think everybody needs to by any means go to the hospital to be seen face to face. And suddenly, after spending years and years trying to sort of convince all and sundry that you could actually do video consultations or virtual consultation with patients, all the issues about governance and everything seems to have melted away, and thankfully so, because it clearly has shown a way of delivering care as well in long-term conditions. I think issues such as the acceleration of things like Freestyle Libre or use of remote monitoring has clearly helped and shown the way of delivering care. For example, in our clinic, most of my care is now virtual, and having access to remote monitoring or seeing the blood glucose results, you can do a lot of care that way. Importance of pathways, I think the important point to make about that is that the national team, along with working with stakeholders, have tried to create as much guidelines as possible around diabetes, what to do if you've got COVID-19 and a background of diabetes, you get admitted, what to do if you're staying in, what to do if you're discharged. They're all available on the ABCD and Diabetes UK websites for use in any hospital setting or community setting in case you already don't have any pathways. As regards, we'll talk about prioritizations, I'm sure, during the course of this meeting. But I think a very important point of this whole exercise has been seeing the leadership. And as ever, NHS does have its variations in leadership, but from the diabetes community, no question that there have been lots of individuals who've stood up, who have tried to modulate the local services accordingly, which has been very, very welcome to see. So, and finally, I just wanted to briefly mention about the impacts on the BME community, as has been documented, lots of debate as to the relationship of that with deprivation, and I'm sure the next speakers will touch upon that, especially Wasim has done a lot of work from the South Asian Foundation, so to speak, about the impact of COVID-19 and resources out there. I think one of the things that we will concentrate on is in these present times, as we are expanding beyond just the remit of diabetes, we are on a day when we talk about vaccines, etc., coming through. It will fall on all of us how we convince populations across the board, including the BME population, the importance of taking vaccines, the importance of what you can do with diabetes in the background. And finally, one of the issues that I wanted to mention was what we do have is an understanding that if you do have diabetes, then you do have higher risk factors. The question is, what do we do about it, and how do we reset the NHS, so to speak, when we're moving forwards? So there'll be two groups of people I anticipate which will be under focus. One will be a much documented, much talked about prioritization. You can hear about some of those, for example, from our other speakers, but the Primary Care Diabetes Society certainly has created an extremely good document as to which group should be prioritized, etc., how we can look after them in virtual clinics. But the bigger issue will be the ones who are not prioritized, as I think we need to ensure that their care is also picked up after a significant period of hiatus of time. And I'll finally finish this particular bit by saying that we're also tracking a lot of data as regards outcomes. Amputation data in diabetes certainly hasn't gone up, which could be a combination of many factors, including the fact that people are mobilizing less. Higher risk people at higher age groups have also unfortunately died. But admissions due to ketoacidosis or hypoglycemia also haven't gone up, which could be a combination of people being at home, less socializing, or indeed less tinkering from healthcare professionals. Whichever be it, at the moment, the outcomes seem to be where it is. So I'll probably finish with that rapid run through, so we have some time, as I said, for more questions at the end, and other speakers find some time to go through the bits that they would like to talk about. Thank you very much, Graham. Hope that's a short, sharp summary of where we are.
Brilliant, brilliant. Get a couple of minutes back. Fantastic. Run through. And just the overview of the complexity of diabetes and its interrelationship with so many other diseases, not only from prevention and the overlap with other conditions, comes through very strongly in the words you say there. We need to remember that multifactorial approach to patients. Thank you. So next up, Stephen, who's going to talk about patient flows and pathways. And again, Stephen, if you could formally introduce yourself, and the floor is yours. Thank you.
Graham, thank you very much for that introduction. So my name is Stephen Wiggcroft. I'm a consultant cardiologist. I work in Leeds in a large heart attack centre covering a population of just over 3 million patients. And you might ask, why is a cardiologist interested in resetting the NHS after COVID with relation to diabetes? And I think what's evident is that a lot of my patients have diabetes. Diabetes predisposes to cardiovascular disease. That's one of the largest causes of morbidity and mortality in patients with diabetes. And I think there's a changing emphasis on recognition that it's not just blood glucose control, blood sugar control that's important in diabetes, but it's in protecting patients from developing cardiovascular disease and needing to see people like me. So we've recognized in Leeds, on the basis of audits a couple of years ago, that a lot of our patients presenting with heart disease had diabetes. So between a quarter and a third of the patients I see have diabetes, and they do much less well than their counterparts without diabetes. And we realized that there were gaps in the way these patients were being managed. Very often their sugar control was not great, but equally we realized that they were not necessarily receiving the best evidence-based therapies in terms of preventing cardiovascular events. And that's based on really compelling evidence over the last 5 years from large randomized clinical trials that have shown that two particular diabetes drugs in particular, so that's the SGLT2 inhibitor class of drugs and the GLP-1 receptor agonist class of drugs. Both of these have shown major benefits in patients with type 2 diabetes in terms of preventing cardiac events, preventing hospitalization with heart failure, preventing worsening renal function, and also preventing heart attacks and strokes. And the benefits of these drugs are accrued early. So treating patients with these kind of medications can make a big difference and is important in a post-COVID era in terms of reducing admissions to hospital and the associated morbidity. So not only have we seen that the evidence is there, but I think we've seen that the uptake of these medications across the patch in the UK has been slower than might be desirable. And part of that relates to the fact that national guidelines, such as NICE guidelines in terms of diabetes management, require updating. But we do know that several pieces of international guidance recommend that we move not not just in terms of blood sugar control in diabetes, but more looking to the type of drugs we are using to achieve that. And more specifically, introducing drugs like the SGLT2 inhibitors or the GLP-1 receptor agonists, regardless of glycemic control, because of their benefits on the cardiovascular and renal system. So what we've done in Leeds over the last year is developed a dedicated cardiometabolic pathway. This is a secondary care pathway, so this is designed to allow my colleagues in cardiology team to identify patients with diabetes and see where their medications can be optimized to improve their outcomes. And we've generated a cardiometabolic pathway. It was an interdisciplinary piece of activity, so we brought together cardiologists, diabetes specialists, primary care colleagues, pharmacists, and our commissioners to develop a pathway in secondary care, along with a dedicated clinic, a clinic pharmacy-led clinic run in secondary care, bringing together expertise from cardiology and diabetes to help to identify these patients who may benefit from these particular medications. And our plan through this clinic is to work with primary care colleagues, primary care networks, and ICS to try and work out pathways where we can optimize therapies across the whole community. And we're looking at using digital methods to do that. And also we feel the best approach is using pharmacy-led services and pharmacy-led approaches, because here is where there is growth in practitioners who can really identify these patients and make an informed decision about the right medications for the right patient at the right time. So I think in the interest of time, I'll probably wrap up my presentation there and then take any further questions in the discussion towards the end, Graham.
Thank you very much. Interesting, the system approach, I guess, is what you're referring to there. And historically, the meds ops teams have been quite maybe cocooned in one part of the system and maybe not thinking of that pathway down the line. And increasingly, we need to think about the commissioning of the pathway. That's what we do at one end may have an outcome at the other. And of course, that may not be in the same financial year. And so that's been a problem for us to implement that. But maybe ICSs will give us a broader way forward. Thank you, Steve. Just remind the audience that you can pose questions as we go along. Please do so for the Q&A. And we'll allocate those as we go along. Thank you, Stephen. Okay, so next up, Naresh. Naresh is going to talk about the digital elements of the system, and the floor is yours. Again, please introduce yourself fully, Naresh.
Thanks, Graham. I'm Naresh Kanimeli. I'm a GP in South Manchester and also a community diabetes consultant based in Manchester Royal Infirmary. I think nobody will argue with the fact that we have changed how we work. And not only that, we've been actually forced to change the way we work. I think COVID has brought about a lot of changes within the system. And like Partha, we were arguing for a lot of these digital technology to be available for us many years ago. But I think the pandemic has forced people to look at faster and quicker ways of putting digital technology into the system. Now, we all know that a lot of the data that's come out of NHS England is actually forcing us to do a lot of audits within the practice to try and identify people with diabetes who probably are at high risk of having more serious complications associated with COVID. Not only that, I think I've had my appraisal this morning, and a lot of my CPD today was mostly about developing audits and looking at tools to try and identify high-risk groups. And one of the things we did was looking at the stuff that Stephen's talked about now about the cardiovascular outcome trials and how do we prioritize patients. We started looking at people with basing audits and searches on the fact that all the parameters that we use in the cardiovascular outcome trials to identify people who would benefit from earlier interventions by using therapies such as SGLT2s and GLP-1s. The other thing to think about is digital has also enhanced the way we work with people with diabetes. I know because of COVID, we're not allowed to bring people into the service initially, and a lot of people missed out on their annual reviews and various other up titration of therapies, etc. But now with various tools that are available, like Attend Anywhere, in primary care we use AccuRx, and some people are using Microsoft Teams, etc., to try and engage with people with diabetes and to try and ensure that they have their time medication up titrated, etc. So we're doing a lot along those lines. And the other thing that Stephen talked about is how do we use guidelines? I mean, using guidelines and developing pathways has also been made slightly easier by using technology for us at the moment. So in this pandemic, what has really come out, I think, is the fact that technology has come to the fore. Now, a lot of us were under the impression that people would not take on this technology. In my practice, when we started doing telephone consultations, possibly about 3-4 years ago, there was a lot of reticence from the people or the patients within our practice that they did not want to have telephone consultations. They'd rather come and see people face to face. Now they've taken it on board, and they also feel that actually they can speak to us at any time that is convenient for them, and they don't have to come to the practice and wait for a few hours before they're seen by the GP. So it's kind of helping them a lot. And not only that, with digital technology, we were able to engage with the carers as well. So it's done a lot of good for us. But one thing we need to be careful about is using technology can sometimes also have negative effects as well. The fact that we might miss important signs and symptoms, non-verbal cues are a big thing in consultations, and I think we tend to miss those. But I think if you do the appropriate preparation during a consultation or prior to a video consultation, I suspect we can overcome a lot of that. Now, many of you would have heard about the other apps that have come about, like GP in Hand, etc. That was in London initially and has moved across to Manchester, etc. And you see a lot of people taking on the GP in Hand because one is convenience. They have access to a GP at any time that they want. But secondly, we also need to be aware that GP in Hand also takes away some of the commitments, not the commitments, about the engagement of the local population with their local GP. So that's one important thing to think about. The other thing to think about is, does digital technology, is it available to people of all social economic status? That's one thing that we really need to focus on and try to overcome, because it's all right for people who have access to technology to be able to access all the digital tools and everything and probably improve their outcomes. But what about the people who are not able to access technology? What about different languages? When we provide information, are we looking at different languages? Are we looking at health literacy, etc.? Those are the important aspects that we need to really consider when we're talking about digital technology. And again, the pandemic has introduced a lot of other options for us. Remote medication reviews. We talked about remote consultations. There are a lot of guidelines available now to try and do remote foot checks, etc., etc. So in effect, just because we're in a pandemic does not mean that we can't provide the optimum service and thereby improve outcomes for our people with diabetes. I'll stop there, Graham, and I'll just let the next person take over, and I'll take questions later on if that's okay.
Yep, thank you very much. And actually, you raised the issue about the inequalities in digital, which is one of the questions about digital poverty, which we may well come back to in the Q&A. Thank you. And it's a bit of time. Move on to our final speaker, Wasim, who's going to talk about leadership. So again, Wasim, please introduce yourself, and the floor is yours.
Cheers. Thank you very much, Graham, and thank you very much for the organizers to give me an opportunity. So my name is Wasim Honey. I'm a professor of diabetes at University Hospital Birmingham. I've got a lot of national roles. I'm a board of trustee of Diabetes UK and South Asian Health Foundation, and have been involved in various kinds of leadership roles for a very long time. Now, just taking on from my previous colleagues who have actually set a scene, and I just wanted to put forward to you some of the ways that we can actually look forward in terms of working in the future once we come out of the pandemic. Now, one of the big challenges which the pandemic has actually posed us is going to be what we call the long-term consequences of the pandemic. I'm being an optimist by nature. I'm reasonably certain when it comes to COVID, say 6 months from now, with the second vaccine coming in play, we should be over the acute phase of the pandemic. We won't have people coming into the hospital and sadly dying. But what the pandemic will actually leave us is what it has done for a year in which we have not been able to offer optimal care to our patients with long-term conditions. And when I say long-term conditions, the top among them is type 2 diabetes. We know nationally it's about 8% in my patch in Birmingham. We are talking about 12% population because of inner city deprivation, a big BAME population. Now, the consequences that will be left for people with diabetes will not only be felt in diabetes, but it will be felt in Stephen's specialty, that is cardiovascular disease, in renal disease, in eye disease. So what we will be actually seeing is a cardiometabolic renal consequences of the pandemic, and it will be very difficult to actually measure the outcomes in years. Now, what are the challenges and how we can actually look into taking it forward? Now, the way I look at forward is by what I call the clinical leadership. Now, one of the things about leadership in the NHS, and one of the difficulties of providing leadership in the NHS, is that we have, for a number of years, the way we have been trained is that we all tend to work in silos, be it the silos of our specialty, be it the silos of secondary care, primary care, community services. And you know, my good friend Partha, for a number of years, has been trying to dismantle these silos so we provide seamless care. Now, this pandemic actually gives us no option but to provide that seamless care pathway. Now, if we are going to be looking at seamless care provision of services, we will have to go over the contractual constraints, be it digital constraints, be it data sharing constraints, and these have to go in, and they have to go in as fast as we have adopted the digital technology. The way I see forward, the way we can do is that we start commissioning, instead of individual services, what I call clinical pathways. Now, this is going to be very important, and this could be, say, from a diabetes point of view, it should not be a glucocentric pathway, but a cardiometabolic renal pathway. This is the kind of a pathway that is based on evidence, what Stephen told you about. There is a lot of evidence to show that if we optimally treat the patients at the optimal medication, we can stop the consequences of diabetes for a very long time. And the reason why we need these pathways and commissioning of these pathways is the challenges that we currently have is that we cannot prioritize, although we have got which patients to be prioritized, but in another 6 months' time, all our 3.2 million or 4 million people with diabetes will need to be prioritized and seen. And the way we can do it is if we have pathways by which we can deliver the care, not doctors, but everyone in the healthcare, be it the nurses, be it the pharmacists. So we need a multidisciplinary approach to try and commission these pathways. Now, I would probably want to end up by just trying to give you an example of what we have done, or my experience. I'm not saying this is an example of good practice, but this is what we have attempted. So in Birmingham, we have tried to implement what we call a cardiometabolic pathway. The way it has been done through a kind of a group that involves both the primary care, secondary care, medicines management, and we have been able to have a cardiometabolic pathway that is cost effective, follows all the national guidelines, including the NICE, and has been approved by the area prescribing committees. Now, but to implement this pathway, we need a vehicle, and our vehicle was going to be a multidisciplinary approach, primarily based in the primary care, that would have involvement of the secondary care physicians along with the GPs, diabetes specialists, nurses, and this was a cardiometabolic pathway along with the pharmacists who are going to play an important role. But the pandemic has obviously stopped that. So I think in terms of the future, we will need these kinds of pathways to take it forward. And the other important thing, why are these pathways? Because I think these pathways will be an important tool for us to to overcome the health inequalities that we see in our societies. These health inequalities are based on social deprivation. I agree that's the most important factor, but the other factors, the factors around in terms of ethnicity. When you talk about ethnicity, there are a lot of factors that come into play other than deprivation. This is the way people access healthcare, and this could be different for different communities. And as we become a more diverse community across the country, we have to look at diverse ways of delivering care. So at that point, I'll probably try to wrap it up, Graham, and that gives us a good 20 minutes for discussions.
Great, thank you very much. Just actually, whilst the others are coming back on screen, you've all put your cameras on, be great. Just picking up on that, Masim, on the silo working, which you talk about, and the importance of commission, the long-term path, the long pathway, which is critical. It was very health focused, your silos. And actually, this is an area whereby if we look at primary care networks and neighbourhood reflective and the demography right down to areas of high density of deprivation or high density of ethnicity, then there's surely something about commissioning with our local authority colleagues as well from that far end of the pathway. Have you had any thoughts about that sort of real prevention element?
Yeah, you see, when I talk about the silos, I'm going right from the preventive aspect involving public health. I'm involving communities, so right from the prevention of obesity to the prevention of diabetes to remission of diabetes to starting the pathway when you have diabetes and its treatment going into complications, be it cardiology and renal. So I'm talking about the entire spectrum, which starts with the prevention tool being very important.
Yeah, good. I think it's important to do that. I mean, and from Naresh, from the community perspective, are you also seeing that engagement now of local authorities in the prevention agenda? Because it's really, I mean, pre-drug, we need to be playing this in, don't we?
Absolutely. I think there's a lot of engagement from, especially because of Manchester being devolved. The Greater Manchester Health and Social Care Partnership is doing a lot of work with obesity, childhood obesity as well, and trying to work pretty hard with the National Diabetes Prevention Program to try and stop the onslaught of diabetes within the area. So, and I mean, we are lucky enough to get a lot of pilots in this place with regards to low-calorie diet and things like that. So I think we're doing a lot, but I think there's something to be said about trying to empower the person with diabetes to try and do a little bit more self-care, and especially the non-diabetic hypoglycemia stage, how we can get the local authorities to enable the citizens to be able to access leisure facilities and all these things, So I think there's a lot of work needs to be done in the background, but a lot is happening as well.
And Partha, on the NDPP, which been mentioned there, are we supporting that going forward? Are we going to see long-term support for the NDPP? Sorry, Partha, you're muted, Partha.
There we go. Sorry, it's the tagline for 2020, isn't it? You're on mute.
Sorry, yes.
No, thanks for mentioning the NDP. I'll come to that in a minute, but I think just picking the point you said, a very good example of where we could do so much better. I mean, you talk about beyond diabetes, talk about obesity, right? If you look at the tiers we've all set up for ourselves, there's tier 1, 2, 3, 4, and it's a bit like an obstacle race to go through people, because there's so much mixture between local authorities and what's under CCGs, what's commissioned, what's devolved, and it's such a mess. Nobody gets anywhere. So, for example, taking the point you've just said, why on earth are we not saying that, local authorities and local commission work together? Tier 1 and 2 should be one tier, and all this 3 and 4 should be one. You get them, get people together. If you're that high end, why do you have to go through a medic to get to a surgeon? That makes no sense, right? That sort of approach. So I think there's that. And I think the NDPP, I would be very surprised going forward if it's not continues to be a flagship, if that makes sense, because we are being pushed to sort of expand further on. I think the data will be the key to get more of the doubters on board. That's always the key to these things. So going at scale is going to be the main thing. And yes, for sure, it will have a lot of focus from our end. I mean, the change in that, I mean, never the panacea, so to speak, but a slight change in QOF to get the non-diabetic you can see all the drive towards it. which I think is the right approach with this as we sort of move forwards.
And I think again, it'll be coming back to that system approach to, you know, the high end dealing with the low end.
Graham, if I just can come over here to Partha's point, you know, when I talk about silos, you see, you know, trying to overcome this tier system in obesity, but there is a lot of overlap with diabetes. So if you actually look at the diabetes remission program, when we're talking about low calorie diets and diabetes remission, this is the same strategy used in some of the tier 3 and tier 4 programs in terms of the weight loss. So you know, so there is a lot of common ground where these things can be brought together.
Yeah. Before we move off this area, Stephen, I'm going to bring you in on with your patients presenting at, you know, at high end in one sense. Is there a loop back into that prevention? So is there a loop back into the lifestyle, or lost him completely? Well, maybe we'll come back to Stephen then, because actually he's asking me a question. He's disappeared off my screen. Oh, there we are. So do you get what I'm saying? Saying your high end, is there a loop, having had that cardiac event, is there a way that your system loops them back into that prevention to reduce the recurrence, to build resilience and lifestyles, or is that not, our system's not mature enough yet?
Well, it does, Graham. I mean, there are fairly well-established systems for fairly well-established cardiac rehabilitation programs across the country, which do exactly that. So I think picking up people who've had an event, then there are effective programs with lifestyle advice, smoking cessation, physical activities that make a huge difference. And we sometimes forget that. You know, we get very focused on interventions, physical interventions, drug interventions, stents, surgery, but we forget the real difference that lifestyle change can make. So yes, I mean, those strategies there, they work. I would say that my experience is that cardiac rehabilitation programs haven't focused particularly on diabetes over the years. So I think in terms of lifestyle change, weight loss, exercise, brilliant. They haven't really looked greatly at diabetes control, diabetes medication. So I think that is something that's beginning to change. And the other thing, of course, is that this all depends on uptake. And despite many regions offering these programs to people, it's all incumbent on the person actually taking it up and benefiting from it. And then again, we see the same problem, that often those who may benefit most are the people who don't actually take up the offer.
Thank you. Yeah, that's interesting. So the question in the chat box there. So Partha, the question about the update on GERF. Could you give us an update on? You see the questions there.
Can do very quickly. Very short. So the national report has come out. There's 15 recommendations there. It is at the moment we have tried to move it away from becoming too hospital centric, because this is the problem with the GERF at the moment, because diabetes isn't, well, only a fraction of it happens in hospitals, to be honest. So what we are focused on is safety within hospitals, which is primary, and there are some very clear things which might sound well, bizarre that it's not there everywhere. So, but we have made sure, for example, self-management plans. If you go into diabetes, you go into hospital with diabetes, about 30% of trusts didn't have a self-management plan. And guess what? They had high errors. So it was just something as simple as, come on, guys, you know, is something as simple as that. Some of it are wider. For example, we have talked about procurement quite heavily in this one, because I think my personal view is we are a national body. NHS is a single procurer. And I think there's a lot of opportunities there in drug classes that we can have to our advantage. We have slightly shown the way with Freestyle Libre, where we negotiated a national price at a reduced rate and brought it to the population. And I think we need to do more of that. So I think, you know, we need more, you know, drugs that make a difference, but we also need the price to play with. We can't just put it out. So, and I think one of the other areas is we talk about is foot care, is making sure, because one of the things that we get from primary care is that this is all very well telling us to check feet. Where are we sending them to? Is a big question that comes away all the time. So we're trying to make sure that hospitals do have these foot clinics, because, you know, there's a lot of discussion that always goes on what primary care needs to do better, but then you pick up all these patients and we need to make sure hospitals are ready. So I think in summary, some fantastic examples of care around the country, some not so fantastic examples, variation all around the pitch. But I think this was also a doff of the cap, which we've set to primary care, because primary care has been measured down to the bone as far as diabetes care is concerned. We have never done this level of work in hospitals, and it's important to show that there is improvement to be done in all sectors, and that's the exercise. So By all means, it's out there. Please have a look. We will look forward to feedback. We have had plenty of people saying, why are we not doing it in the community? I think it's one step at a time. So we are doing the hospitals first, and then we'll sort of look into what can be done further on.
I think there's some anxiety that gerf and evidence-based intervention programs would drift away under COVID, but actually, in one sense, arguably they're more important, because actually, as we come back online, our resource allocation is tighter. It's important we focus our resources in the right individuals.
Absolutely, absolutely.
Yeah, interesting. I mean, whilst you've mentioned feet, I'm going to go back to Naresh again about community, because there's a question about remote foot checks, but also the wider question is actually from the digital and the remote is how we get, things like foot checks there can be a huge workload, a workforce, sorry, could be trained to do that sort of thing. There's a digital agenda, absolutely, but there are certain things where you do have to touch the patient, you do have to get your hands on them, but actually, remote, that's stuff that we need physically there. So any thought about the wider workforce around doing that sort of thing, using foot checks as an example?
I think Partha will also agree there is a agenda that we should have, which is every contact counts. If the person has not had a foot check, if you're seeing them, you should be doing the foot check if they haven't had one. I think one of the things they try to introduce is if you're going to A&E, for any reason, if you've got diabetes, a foot check would become mandatory. So that would be an interesting step. We were talking about other things as well. When you go for an optician's check, could we get them trained up to do a foot check and things like that? So, and that's one thing. And the other aspect we tend to forget, like again, Partha mentioned, is sometimes we do work in silos, even in hospital, in specialties. So when people go to the foot clinic, they don't have a discussion about their HbA1c and the glucose control. And they come to see the endocrinologist after, and they don't have a discussion about the foot. So it's something that's missing. And the person with diabetes gets dropped off in the middle, that I think in primary care that this is being seen in hospitals, so foot checks would have been done. You guys think, well, they've been seen in secondary care or primary care. So the person with diabetes suffers in the middle. So there is this thing about, especially in the digital world, when the contact is so minimal, we should try and do something about every contact counts. What are we missing in this person? Can we get other people engaged to do that? I think that's the way to go.
Thank you. Wasim, there's a question in the box about follow-up to gestational diabetes. And obviously we know that this is a cohort that will be on the pathway to diabetes in time. And there's a link in there. Are you aware of any support for the gestational diabetic group? How we make sure that they are supported more?
So I'm assuming, so when you're talking about gestational diabetes, you're talking about what I call the real gestational diabetes that comes in pregnancy and goes away, and that puts them at a higher risk of developing diabetes later on.
The ladies who recover postnatally and then
So currently, I think what we're doing, at least in Birmingham, and I'm sure the other places, now most of these women, once they have been diagnosed with gestational diabetes and they get an all clear either with an OGTT after 6 weeks post-gestational, they are signposted towards the National Diabetes Prevention Program as an option, because most of these people have got a high risk of developing diabetes later on. So whether they could access that, and that is being considered. But one of the challenges that we currently have is there is a huge loss to follow-up. And again, this comes like working in the silos, because most of these patients are seen in antenatal clinics with an input of a diabetes team. And once they have that OGTT, they are lost, or they don't get the OGTT post 6 weeks. So they go back into the primary care with very little communications. And the next contact only happens if they get pregnant again. So this is again trying to develop those pathways which will help us to get the seamless working across the board.
Thank you. There's a question here about...
Can I just come in there quickly about what Wasim said? I mean, it's something that you and I face in primary care. I think the important thing for us is to ensure they're coded on the system and they're searched for once a year. So that's the most important thing. When they come back from the secondary care, make sure they're coded on the system.
Absolutely. I entirely agree with that screening and HbA1c needs to be there. Just one question at a time. So, Stephen, I put you down for this question, but then all can join in. It's about, because with the rehab we discussed with you, there's a question there from Ivan about the non-engagement and then the psychological and behavioural changes I think you can see it there. We want to do rehabilitation, and I think it could, well, everyone's involved in that. But actually, do we have any fail-safes for those who don't engage behaviourally or from psychological reasons?
I mean, that is a really good question, Ivan, and I think there's a whole host of reasons why people might not engage, as you may imagine, and they can range from social regions, cultural reasons, language barriers, financial reasons, and it's all very well rehabilitation teams telling or advising people to eat healthy, take more exercise, join a gym, etc. But there are often barriers in the way to doing that. I think one of the first barriers is actually getting in contact and getting some engagement with the individual in the first place. So there are lots of strategies that are employed to do that. Because rehabilitation is often delivered differently in different locations, and each community service has its own way of delivering it, then there are initiatives such as making sure information is translated into different languages, having champions from different ethnic groups who can contact patients and try and encourage them to participate, giving advice on diet that is not expensive, not a matter of eating expensive food types. So there are various approaches that have been used, and I think the other thing that helps is to just reinforce the importance of this at interactions with healthcare. So I think certainly my own specialty in cardiology, not always as good as we could be in terms of emphasizing the importance of that when we see patients as consultants in clinics and on the ward rounds. And I think that does make a difference. There are lots of different approaches, but I don't know if there's any one that is sort of universal that's well deployed.
I think it plays into the no health, mental health mantra. There's the issue about actually we naturally silo issues, and actually offering psychological support. We know long-term CBT in parallel with long-term condition management improves outcomes in diabetes if you support people with their psychology. So it's maybe it's an area. I mean, Naresh, from a community perspective, or from a primary care perspective, have you seen the examples whereby someone's can catch the emotional well-being of these individuals to try and support them on the journey?
I think one of the big things that we're talking about now is how to engage with the carers. I think that is one way to engage with them, because we know the important aspect is how we as consultants or GPs or doctors promote these things as actually part of their therapy. If we don't do that effectively enough, they're not going to take it seriously. But one way we found was actually how do we get engaged with the carers and the family members to try and say, well, actually try to convince them as well, this is an important aspect of their lives as well. So that's one way to do it. Like Stephen says, there are multifactorials why they don't engage with us. I think trying to find that may help us. Psychological support, which is very few and far between for the people with diabetes or post MIs and things like that. If anything that can be done about that, maybe the transformation funding that's coming along, maybe that we can use that to try and help develop these services beyond just looking at the clinical aspects, looking at the social economic determinants of health there.
And we know the link between MI and depression, don't we, as well? That's the adverse there. So, Partha, I'm getting a bit about time here. Partha, on the back of COVID, I mean, are we getting good analysis of the data? Are we seeing, HbA1c rates falling off in primary care? Is there an issue with remote education when we've got new diagnoses? Are all these areas being tracked? I mean, I appreciate it's quite recent.
Yes, it is. I think in short, that's actually one of the fundamental things which we are doing, because I don't think, and in fact, I firmly believe that's what the NHS should be doing across the board, because otherwise we run the risk with very finite resources of trying to do everything. And I've been very vocal about this in all my, whatever I write and say, that the NHS needs to be very clear it can't do everything for everybody as we are progressing, and that includes diabetes. So when people turn around and say, oh, you prioritize foot clinics, why did you do that? And the answer is because we can't do everything, and we have to pick the one which has got the biggest impact. Now, people may disagree with that, but that's where we are at. So I think going forward, the prioritization, once it happens, we all know in this call what will happen. There'll be some group, which is already starting with the vaccination program. You're seeing people going like, well, why not us? And why not us? So I think they will, which is why the data is so important. So to your question, yes, we are tracking the data, and our prioritization or focus will be based on that data as it goes along. And sadly, it will not include everybody. And that's the whole point of prioritization, so to speak.
Yeah, and of course, you say prioritization, and so I say prioritization, but the person across the table might call it rationing. That's the challenge. That's the challenge.
100%. That's the debate we always struggle to. And I'm not going on my soapbox, but I genuinely think this is where we kill ourselves. This whole thing about, primary care can do all of the vaccines, and I keep on going, but what are they stopping? They've still got a finite workforce. At one point, they will keel over unless they're working throughout the night, every day, that sort of stuff. So I think people need to be realistic as to what the whole workforce can do.
Well, there's lots of debate. I mean, I think the digital agenda has been really important. The debate, the information sharing, we've had freedom on that, and COVID recent. Let's hope that information sharing freedom carries on. I guess, drawing to a close now, I guess the important thing is that we understand the continuum between the prevention and the specialist interventions at the far end. The importance of merging the acute care to the community care. This is all long-term plan stuff, isn't it? This is all stuff that's basically a long-term plan, and which is the right direction, which we think we all sign up to, and it's been expedited by a crisis. So I guess it's beholden on all of us to make sure that we still go in the right direction and don't take the brakes off when you get the vaccine and say it's all okay, let's go back to 2019. Let's not do that. So I think, drawing to a close, I'm sorry it's been short on the questions, but I had that technical stuff at the beginning. So I'll just thank all the 4 speakers for his day. Thank all the delegates for joining us and listening in. And thank you for your questions, and thank you all for your time.